You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for December 11th, 2020. This week, a correction, COVID, the clogged pipe framing of coronary artery disease, paclitaxel, and atrial fibrillation and Goodhart's law. Now first, a correction. Last week I misspoke at about 12 minutes into the podcast. I was discussing type 1 and type 2 MIs and was referring to definitions laid out in the Fourth Universal Definition of MI, a paper I will link to. In a brief review, there are essentially three categories of troponin elevation in MI. First, there's type 1 MI, and this is due to plaque rupture. It's an acute syndrome of either STEMI or non-STEMI. Type 2 MI is a troponin release from acute myocardial ischemia due to a mismatch in oxygen supply and demand. Examples of type 2 MI include coronary spasm, dissection, a sustained tachycardia, severe anemia, or hypoxia. The third category is acute or chronic myocardial injury due to conditions like, say, myocarditis, heart failure, Takotsubo, ICD shocks, CKD, sepsis, PE, chemotherapy, and even strenuous exercise. Now, the way to sort out acute versus chronic injury is whether the troponin delta is positive or not. Now, the reason I misspoke is that I meant to relay the key therapy message, and that is that type 1 MIs should be treated as an ACS. It's plaque rupture. And if it's a STEMI, go emergently to the lab. If it's a non-STEMI, admitted to the hospital. All other troponin elevations, type 2 MI and acute and chronic myocardial injury, should be approached by looking for the underlying cause and treating that condition. All right, next topic is COVID. As you know, the U.S. is struggling with a third spike. Here in Louisville, at my hospital, we've stabilized at about 20% of our census. We have not yet had to stop doing elective cases, but Louisville, Kentucky sits on the border of Indiana, and the governor of Indiana has told hospitals to stop electives. And I don't know about your situation, but I feel like COVID is just everywhere. I mean, I probably know 100 people who have had it, and they know 100. The virus's ability to spread is just shocking. This makes contact tracing seem like utter folly. But that's the bad news. The good news is the vaccines. The main results published in the New England Journal, get this, for this is a Pfizer vaccine. There were 8 cases of COVID among participants assigned to the vaccine and 162 cases among those assigned to placebo. The FDA committee, which met yesterday, recommended approval. We still need more data on safety, but here is a prediction. Write this down. Okay, consider that Eric Topol tweeted yesterday that it's possible that 80 million Americans have had COVID. Now let's say that 10 to 20 million are vaccinated in January, many more in February. Let's also say that the majority of those vaccinated are high-risk patients most likely to be sick. Now add in the people with immunity from having had the infection, and in some areas that is a lot. Barring a negative vaccine surprise, I predict we'll be largely out of this mess by late spring or summer of next year. Next topic is the clogged pipe theory of coronary artery disease. An observational study from Danish authors, published in JACC, further refutes our false notions about the clogged pipe frame of coronary disease. What do I mean? That focal stenoses are the culprits. Finding these focal blockages via stress tests, then angiography, and fixing them with revascularization, this is the engine that drives most cardiology offices. I mean, why else would we buy so many nuclear cameras and treadmills if not to find ischemia? But we know from Courage and Berry 2D, and more recently from ischemia, that fixing these focal manifestations of atherosclerosis does not improve hard outcomes, no matter the scariness of the blockage. In the Courage and ischemia trials, proximal LADs, double vessel disease, triple vessel disease were all included. In these subgroups, there was no advantage to adding PCI to optimal medical therapy. Did you know, for instance, that the original cabbage versus medical therapy trials done in the 1980s were null? The primary endpoint, null. The field of cabbage took off based on a subgroup analysis of trials in which the primary endpoint was no difference. For instance, the left main cohort that did better with cabbage included about 150 patients in the two trials, and this was before the era of high-intensity statins. 150 patients. So I would propose that if a Martian came down to Earth and looked only at the data, he or she would be utterly convinced that Dr. Bernard Lown was right to say that coronary artery disease is a very, very stable condition that is best treated medically and with lifestyle, and intervention should be reserved only for those with unstable or refractory symptoms. Okay, now to the Danish study published in JACC. The question the authors had was to see if obstructive coronary disease, the kind that causes ischemia, provides predictive value beyond its association with just run-of-the-mill calcified plaque burden. The authors used data from a registry of nearly 24,000 patients who were referred for a coronary CTA because of suggestive symptoms. The endpoints of this observational trial were major cardiac events, and the follow-up was about 4 years. Now, to our Martian friend who is not encumbered by any entrenched beliefs about scary pipes, the results would be not surprising. The event rates go up as you would expect with increasing number of vessels with obstructive disease. Number 2, event rates also go up with the increasing amounts of coronary calcium. But the key message of the study was this: when the authors stratified by calcific burden, the event rates were similar in patients with and without obstructive disease. So plaque burden, not the number of stenoses, was the main predictor of future events. Thus, patients with a comparable calcified atherosclerotic burden generally carry a similar risk for events, regardless of whether they have non-obstructive or obstructive coronary disease. The two key clinical implications here are A, it's the degree of atherosclerosis that is the issue, not the fact that there are focal stenoses. And B, the authors feel that this data should stop the distinction between secondary and primary prevention when it comes to initiation of preventive therapies like statins. Now, before I comment on that, let's first note that this is observational data and it has oodles of limitations. I mean, there could be uncontrolled confounders that account for the findings. There was also relatively crude and subjective dichotomization of yes, obstructive or no, non-obstructive disease. But I see that these findings surely comport with clinical trial data that urge and plead and beg us not to see focal stenoses as the widowmakers. And on the matter of primary and secondary prevention, I don't think we need this study to nullify this false distinction between primary and secondary prevention. Here's why. All patients with or at risk for atherosclerotic disease ought to be counseled about lifestyle intervention. Daily exercise, I tell patients, is like a heart pill. For instance, another common thing I say is eat only on the days you exercise. And as for statins, the drugs reduce cardiac events by 25%, period, whether one has had an MI or not. If you are higher risk, your absolute risk reduction from a statin is bigger. Now keep in mind that normal people don't have these pseudo thresholds like 7.5% 10-year risk by which they decide on taking a pill for the rest of their life. This is why I'm so down on using coronary artery calcium as a screening test or risk modifier. I think it's simple. You put the patient's clinical numbers in a risk calculator, then you multiply that by 0.25, which is a statin risk reduction, It can show patients their risk on and off the drug. Some will decide to take the drug, others will not. For instance, if a person wants to do everything they can to prevent stroke or heart attack, they will not be motivated by the small movements in risk from a coronary calcium. They will just simply take a statin. And even if the coronary calcium could accurately reclassify risk, it can, then that reclassification would not alter decision-making in most patients. Okay, next topic, paclitaxel and peripheral artery disease. A recent published randomized controlled trial provided reassuring news on the commonly used drug in peripheral artery disease. It's really good news because the story of paclitaxel in peripheral artery disease was getting concerning. Paclitaxel, otherwise known as Taxol, is an anti-cancer drug that is also used to coat stents and balloons so as to prevent normal inflammatory processes to cause restenosis over the long run. This is because when we, quote, fix a blockage, it may look pretty on an angiogram, but we're actually damaging the vessel wall. And for reasons that are unclear to me, peripheral artery interventions use mostly paclitaxel, whereas in coronary disease, there are a number of different anti-proliferative drugs that are used for coating stents. In 2018, a meta-analysis of studies identified a signal of excess mortality among patients with FEMPOP disease who were treated with devices that used paclitaxel. This was an unexpected finding. Mortality signals surprised people. It didn't make sense because the dose used in these devices in the leg was really small. But then an evidence review by the FDA and some other observational studies also found this similar signal of harm. This controversy actually caused a major randomized controlled trial called SWEDEPAD to pause enrollment. SWEDEPAD is an RCT comparing revascularization of peripheral disease with drug-eluting technology versus revascularization without drug-eluting technology. Now, SWEDEPAD began in November of 2014. It was supposed to enroll 3,800 patients, and it had separate endpoints for two cohorts. One endpoint was amputation for those patients who had critical leg ischemia, and the other endpoint was quality of life for patients who had claudication. All-cause mortality was a secondary endpoint in both randomized groups. But enrollment was paused after the 2018 findings. It was resumed in 2019. Recently, the New England Journal of Medicine published an interim analysis on about 2,300 patients entered before enrollment was suspended. During this mean follow-up of 2.5 years, 25.5% in the drug-coated device group had died versus 24.6% in the uncoated device group. We have to remember that SWEDEPAD was not a trial designed to look primarily at mortality, but I see this as strong and reassuring data because the total of more than 570 deaths is more than the combined total of deaths reported in 36 previously published RCTs. And of course, other strengths of this analysis was that follow-up was substantial at up to 4 years, and no patients were lost to follow-up. This interim analysis may not completely close the question of paclitaxel safety, but it surely resets the equipoise needed to continue ongoing clinical trials. Okay, final topic today is a quick note on new performance measures for atrial fibrillation. An ACC and AHA task force on performance measures have made 2 changes to these performance measures for adults with AFib flutter. This was a 2020 update to the 2016 document. Now, before I tell you the details of any of these performance measures, we should always discuss Goodhart's law when it comes to performance measures. The British economist Charles Goodhart wrote that, quote, any observed statistical regularity will tend to collapse once pressure is placed upon it for control purposes. That sounds pretty complex, and it was later generalized to mean, quote, when a measure becomes a target, it ceases to be a good measure. All doctors know this. Now to the document that updates new ways to measure how good a clinician is in taking care of people with AF. So there's 5 of them, quickly. Chad's VAS score should be documented prior to discharge. Anticoagulation should be prescribed prior to discharge. If you prescribe Coumadin, warfarin, an INR should be planned in follow-up. And CHA2DS2-VASc score should be documented during outpatient encounters, and of course, anticoagulation should be prescribed according to the CHA2DS2-VASc score in the outpatient setting. Okay, my comments. My views on measuring clinicians' performance have evolved. When I arrived in private practice, I was frustrated that one's skill had nothing to do with getting referrals. Referrals came based mostly on previously set patterns and name recognitions. Then, as performance measures came to be the norm, I soon realized that the old way may not have been so bad. That is because the notion that we would measure a clinician's skill by how good we are at box checking was just jarring to me. I thought, how could smart people think something so nutty? But now I'm just numb to the metastatic spread of smart phrases and box checking in the electronic health record. I don't even get mad anymore when I see a big red box warning me that my patient with an INR of 3.5 needs to have VTE prevention ordered. Now back to these new performance measures for AFib. Of course, it is good to think about anticoagulation in patients with AFib. And whenever we start warfarin, there needs to be a really well laid out plan to check INRs. These performance measures will simply generate pop-up boxes to click through. Sadly, none of the warning boxes that require clicking through will have a discussion about the C statistic of the CHA2DS2-VASc score. The C statistic, of course, is a way to measure a test's ability to predict future events. The C statistic of the CHA2DS2-VASc score is slightly better than a coin toss. It's terrible. So, therefore, based on these performance measures, let's take an example. A person has a massive left atrium, which of course, left atrial size is not on the CHA2DS2-VASc score. This patient also has permanent AFib, and he's 64.5 years old, so he's not 65. His CHA2DS2-VASc score, as far as the box checking goes, is 0, and he should not be on an oral anticoagulant. And if you use an oral anticoagulant, you're going against the performance measures. You're not performing well. Now, the performance measures proponents will counter that all the doctor has to do is document this or that reason for deviating. And that's fine, except time is finite. And time spent satisfying documentation is less time making a connection with the patient, less time crafting a message of what is important in AFib care. So to summarize, of course I don't know the best ways to measure the quality of a clinician. Maybe it's not even possible. For now, I think the best way through the gauntlet of administrative nonsense is to manage as gracefully as possible. My advice is to spend time with these inane smart phrases. Get them down pat. Learn to quickly through the boxes, because the faster you can make the EHR look good, the more time you have to spend with patients. Okay, before I close, a quick shout out and a request. First, I want to thank people for pointing out any errors that I make. It really means a lot to me that people listen this closely. And second, it really helps if you like this podcast to take the time to give us a rating or write a review. That way others can find us more easily. So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.